Radiology was once the most sought after investigation by the society and by the public. Today, it may have been outdated by the CT scans and MRI, but still the gold standard to diagnose in a general practitioner for any ailment within the lung, I think the X-ray has never been matched by anything, and for a general practitioner, it is the first investigation for any ailment in the lung. And here is Dr. Murugan, who is a professor in the College of General Practitioners, to give you the entire episode description of how you go about reading an X-ray chest.
Hello doctors. On behalf of IMA CGP, I am glad to address you on the first occasions of Radiology CME. Now this is regarding the basics of chest X-ray. That is, every doctor will be encountering 1 or 2 chest X-rays in their daily practice. So we should know how to go about interpreting a chest X-ray. This forms the most common radiological investigations that is done all over the world. Next comes the ultrasound abdomen. Now in the interpretation of chest X-ray, we have certain protocols, like we first verify the name of the patient, date of the X-ray, the side mark, then the other technical parameters like is the film centered well, or is it a PA or AP film, or is it exposed properly, or is it done in a good inspiratory phase. Now first 3 points like name of the patient and date of the examination is very important, as we should first verify whether it is corresponding to the person that is being clinically examined. One. Then the date of examination is very important, because a serial of X-rays might have been taken for the same patient, and you should know the progression of the disease based on the date of examination. And then the side mark is very important. As you all know, there is a condition called situs inversus and totalis and situs inversus solitus. And these two conditions has to be identified based on the correct side mark and the position of the heart. Then the technical parameters like the film centering. We will come to that. Now, how will you see whether the X-ray has been centered well or not? You look at this particular X-ray, wherein you find that the trachea is shifted to the right side. Now, is this because of any problem in the patient, or is it because of the radiographic positioning? Let's go to the next one and see. Now this slide shows that this particular X-ray is not centered, as you draw a line along the spinous process of the vertebrae that forms the central line of the patient's body, and the medial end of the clavicle should be at equidistance from the line. Now this particular X-ray shows the right clavicle is away from the midline, so it is not centered properly. So whatever the impression that it gives, the trachea shifted to the right, is not valid. Now with these pictures, you should not comment about the mediastinum, because aortic knuckle appears unduly prominent and you see only little amount of heart border on the right side. So this should not be taken for the mediastinal shift. Then the next one is it a well-centered X-ray? Just to find out. Now you see that you draw a line along the spinous process and the equidistance from the medial end of the clavicle that are equidistant from the central line, which shows that it is a well-centered X-ray. Now you should also know, is it a PA or a AP film? Why should you know whether it is taken in an AP projection or a PA projection? Normally the X-rays are done in a PA projections because of the technical reasons that I will be giving you now. Now you see another X-ray which is again well different from that of the previous X-ray. Now if you go to the technical parameters, now all the standards that are given in the chest X-ray is for mainly chest X-ray PA view, and because this is taken in erect posture and the act of gravity acts upon the vessels and that changes the pulmonary vessels shadow and cardiac size. It is also depending upon the whether it is taken in PA or AP projection, and the width of the mediastinum. The mediastinum appear widened in a AP view, and you also look at the position of the diaphragm. In normally taken PA view, the position of the diaphragm is at the level of the 10th rib, whereas in an AP projection, this a diaphragm is appearing much more elevated. Now, as I told you now, the heart appears larger in the AP view, the mediastinum is widened, the diaphragms are higher, the pleural effusion layers posteriorly, so you may not see the earlier pleural effusions, and the pulmonary vessel size normally which are prominent in the lower zones are appearing more equal width, and they are equally distributed to the upper and lower lobes because the act of gravity is not there. Now this particular thing is talking about the exposure of the patient. Now normally the adequate penetration is important. Normally the exposure adequacy of exposure is one important factor which is very important to determine whether there are subtle lesions in the lung field. If it is an overexposed film like this, you may not be able to pick up subtle abnormalities. So it should be penetrated adequately to pick up early lesions as well as to identify the vascular shadows behind the heart or in the close to the vicinity of the hilum. Any smaller lesions can be easily picked up. Now, and the third thing comes about the respiratory phase. Now once you take a X-ray chest in a good inspiration, the level of the diaphragm is at the level of 9th to 10th rib posteriorly and 6th rib anteriorly. So when you take an X-ray in the expiratory phase, this is what happens. You are not able to see the lung field as adequately as you see in a good inspiratory film. The mediastinum is appearing widened, the heart is appearing larger, and you may not be able to make out the interstitial markings very clearly, as the vascular markings will appear prominent, can mimic a interstitial lung pattern. Now, can you identify the number of ribs on the anterior end and the posterior end with the chest X-ray? Yes, there is a numbering pattern. You follow this. Posterior ends of the ribs are counted separately and the anterior ends of the ribs are counted separately. So that now when you follow the rib, you can follow from the posterior end to the anterior end and identify for a trauma case which particular rib is diseased or fractured. Now there is a systematic way of approaching the chest X-ray. Now you always start from the soft tissues, that is you come from outside to inside. Now you start from the soft tissues, that is mainly the supraclavicular areas, axilla, breast shadows and the tissues alongside the chest, that is behind the breast and things like that. Now the next comes the bony cage. After the soft tissue, you start interpreting the bony cage. These are all the structures which forms the bony cage. Basically the ribs, sternum, spine, shoulder girdle, that is the scapula, clavicle and the part of the humerus, these forms the bony cage compartment. Next will be the diaphragmatic pleura, diaphragm and the pleural surfaces. Now the diaphragm should be concentrated upon one, whether the dome is maintained and whether the CP angles are sharp, and the pleura should, normal pleura is not well visualized on the chest X-ray PA view, and the fissures are not normally seen except the horizontal fissure because it is lying tangential to the beam of the X-ray. Now the other areas which should be concentrated before we go on to the lung fields are abdomen and the neck. Now in the abdomen, you on the right side you always look for air under the diaphragm, or is the right dome elevated. This can happen due to saphronic abscesses or diaphragmatic paralysis or hepatomegaly and liver pathologies. Sometimes subpulmonic effusion can mimic a elevated diaphragm on the right side. On the left side, you concentrate on the position of the stomach bubble, so that if it is present, if there is a distance, if there is a long distance between the stomach bubble and the left dome of the diaphragm, then that indicates that there is a fundal growth which is displacing the stomach bubble inferiorly. Now then we will come on to the lung field proper as well as the hilum. The lung field proper should be interpreted from starting from the hilar region, and the hilum means it is formed by the pulmonary arteries and veins and superimposed over the lymphatics and the small lymph nodes which are normally not seen in a chest X-ray. Whereas the lung field, you divide it into medial and the lateral halves. Now these are mainly formed by aerated lung which are intercepted by the multiple bronchial as well as the vascular shadows. Now, normally it is said that only 40% of the lung field is visualized by the X-ray chest. Now, this you should take it into consideration whenever you have a positive, clinically positive patient and that X-ray abnormality is not shown on X-ray. Go for axial imaging systems like CT scan and other modalities. Now, regarding the mediastinum, with this mediastinum is the last structure we will be interpreting upon. Now, this mediastinum, thus you have the normal structure. Here it is a diaphragmatic representation of the normal mediastinal structures. On the right side, the inferior-most border is formed by the inferior vena cava. Then comes the right atrium, then a part of ascending aorta if it is unfolded. Otherwise, you don't see the ascending aorta. Then the part of the superior vena cava. Then on the left side, this hot border is formed by the left ventricle initially and left atrial appendage, and then pulmonary artery, then arch of aorta, then a subclavian artery and vein on the left side. Now, these are all the mediastinal borders which forms a mediastinal. This is again a diaphragmatic representation of the mediastinal line, and again the structure which should be concentrated upon on a mediastinum is paratracheal stripes. Look at the aortic arch and as well as the size of the heart. Normally, the size of the heart falls below 50% of the transthoracic diameter of the chest. Now, in case if it goes above 55%, then you call it as a cardiomegaly. But this is only apparent. All the other things has to be correlated with the echocardiographic findings. Then this is a closer view of the mediastinal structures, rather little more penetrated, just to show the trachea, bifurcation, carina, and the relationship, the hilum and the relationship to the bronchus. Normally, this is a left heart border. This shows the aortic knob on the top. Left AP window is otherwise called as an aortopulmonary window. This is a pulmonary artery which are prominent. Left heart border should be carefully assessed because lesions like a smaller lymph node, aortic aneurysms, and mediastinal masses can be easily missed if you are not concentrating on it. Now, normally, basically, how do you assess the position of the mediastinum? That is another question which commonly comes across in the minds of the general practitioner. Now, if you look at two structures, one is trachea for the superior mediastinum, other one is the mediastinum, that is the inferior mediastinum, that is a heart. Okay. Now, this right heart margin and the aortic knuckles are carefully visualized to look at whether the mediastinum is shifted to right or left. Now, the hilar structures, basically the left hilum is at a higher stage than the higher level than the right hilum. This is because of a condition called as, normally the left bronchus is called as an hypoarterial bronchus. That means the bronchus is located inferior to the pulmonary artery. So, this position is of importance because certain pathologies can pull up the hilum or certain pathologies can displace the hilum downward. So, you should know about the position of the hilum just to interpret the X-ray in detail. Now, about the lung field, the vascular markings, how do they normally look at? Now, when you look at the vascular markings, these are more prominent in the lower zones compared to the upper zones. And when you look at the lateral half and the medial half, in the peripheral outer 1/3 of the lung, you don't see the vascular markings normally. When you see the vascular markings, these are considered as pulmonary hypertension, or that is hyperemia in the lung field. Now, anatomical location of each of these lobes are important. Now, this is for interpretation of the pathologies affecting different lobes of the lung. On the right side, as you know, you have 3 lobes, and on the left side it is only 2 lobes. This is the diagrammatic representation which on the location of the left upper lobe and the left lower lobe. Now, if you see in an AP projection, there is a considerable overlap of the left lung, left lower lobe over the left upper lobe. this is predominantly the lingular segment which is overlapping with the left lower lobe. So, when identifying the pathologies of the left lower lobe, you should be careful and use a sign called as silhouette sign, which I will be discussing later on, to detect the pathology, location of the pathology. Now, this is a location of the right upper lobe. Now, this shows the diagrammatic representation of the right middle lobe, and look at, there is a considerable overlap of the right middle lobe and the right lower lobe. Now, after finishing the lung parenchyma, we are coming to the costophrenic angle. Now, costophrenic angles are normally sharply defined. Once you have a blunting of the costophrenic angle, now then you should suspect an early pleural effusion or a pleural fibrosis. Okay. Now, one question that is commonly asked is, what determines the position of the diaphragm? Basically, it is the heart sitting on the left dome of the diaphragm which is pushing it down, because there is no solid viscera underneath the left dome of the diaphragm. It is only the stomach which is easily getting displaced by the position of the heart. So, now in a lateral view, interpretation depends upon which lateral is it. Now, normally the side of pathology is kept closer to the phlegm and you take a lateral view. Now, just you should identify which lateral is this and which diaphragm comes where. Now, this is gives you an idea, because normally right dome of the diaphragm is seen in its extensive anterior, seen in its entirety, whereas the left dome is obscured anteriorly by the position because of the heart is sitting on the left dome of the diaphragm anteriorly. So, if you see a diaphragm which is continuous, that is the right dome, and if you see a diaphragm which is not seen anteriorly, that is the left dome. Now, a diaphragm which is close away from the screen is always looking larger than the diaphragm which is closer to the screen. Now, in a lateral view, another thing which you have to commonly look at is the retrosternal space. Now, the retrosternal space is increased in case of obstructive emphysema and it is decreased in case of right ventricular hypertrophy. Now, right ventricle forms the anterior margin of the heart in a lateral view, and that is depicted again in this picture. Now, what is the significance of the overlying breast shadow over the lung fields? Now, it can mimic, the breast tissues can mimic subtle abnormalities in the lungs. Certain pathologies in the breast can be superimposed over the lung field. Say, for example, a fibroadenoma in the breast can mimic a lung nodule. So, clinical examination or a lateral view is more helpful in identifying such abnormalities, whether it is coming from the breast or from the lung field. Now, so far we have seen certain anatomical locations of anatomical way of interpreting the X-ray chest. Now, we will go on to certain technical factors which will help us to identify the pathologies in the chest X-ray. Now, first, for understanding the pathologies in the chest, you should know how the X-ray is generated and how these opacities are produced. Basically, X-ray is a form of electromagnetic radiation. Unlike light, the X-ray does pass through the body, and the penetration of the X-ray depends upon the density of the objects through which it passes. When you have a chest X-ray, the X-ray beam penetrates in a direction that is mentioned, that is normally in a peer view. Now, there are certain structures which are appearing as white. That means those structures have got a very high absorption of X-rays. Certain structures will appear as that of an intermediate density or grayish in appearance, that of water containing structures and tissues. For example, liver area as well as the heart. Now, certain areas which will contain air will appear as black because it does not absorb any X-ray. Now, there are in pathologies, this density gets altered. As you know, when you have a generalized liquid density all over the lung field, which should contain air totally, you talk in terms of diffuse alveolar disease, or in terms of diffuse interstitial lung disease, or it can be a pathology which is affecting both the interstitium as well as alveoli, as in a case of consolidation, or it can be a vascular shadow like that of an AV malformation and things like that. Or when it is localized, you talk in terms of local pulmonary infiltrate, or it can be a consolidation, a cavity filled with fluid, that is because it's showing a liquid density, and lung masses, then congested or vascular abnormalities in the lung, then focal collapse of the lung because air has been expelled from that area. Now, when you have an air density which is increased or more than that of the normal appearance, you would think in terms of either a bronchial way obstruction, either a generalized or a localized. Local bronchial obstruction means that there is an intrabronchial growth in that particular segment. Then if this particular problem, if it persists, it can lead on to a local emphysematous changes. Then next comes the bulla. The emphysema, when its interstitium gets disturbed, it forms a bulla. A larger lesion with a thick wall is called as a cavity. When the cavitary contents are expelled, when it is replaced by air, it's called as a air containing cavity, which again will show an increased density. Now, when you identify the abnormalities as using the physics that is mentioned above, when you start assessing the pathologies, these are all the areas where you should concentrate. First, identify which is an abnormal shadow. Then try to localize the lesion to the anatomical locations. Like as I said, on the left side, the lingular segment gets overlapped with the upper lobe of the left, upper segments of the left lower lobe. Likewise, on the right side, middle lobe is overlapped with that of the right lower lobe. So you have to localize the lesion to the particular segment and then identify the pathology. What is the pathology that is causing this abnormality? Then identification of the etiology for that pathology. Like for example, when you identify a collapse, then you should also identify whether the bronchus supplying it is patent or not. If you identify the bronchus, then you can easily identify the etiological factor which is causing the collapse of the particular segment. Then you have a clinical assessment, correlate clinically in case of complex problem where you don't get an answer by your clinical examination along with the suspicious radiological opinion, opacity, go for cross-sectional imaging like CT scan and MRI scans. Now we will go on to interpretation of the cases. Now there are a few cases. I will not be describing the pathology in the first slide itself. You make a try on the first slide and then move on to the next one so that you know whether what you are diagnosing is correct or not. Okay, this is the first case where you are able to identify a cavitary lesion in the left upper lobe. Now look carefully, is the wall of the cavity is symmetrical or asymmetrical? Now the answer is, this is a cavity with a eccentric wall thickness which is seen more medially. This type of eccentric cavity in the lung fields, one should definitely eliminate malignancies like squamous cell carcinomas. Now the squamous cell carcinomas and tuberculous cavities can sometimes mimic each other, and you should not miss a malignancy for a benign lesion. Now we will come to the famous Sellout sign. Now any intrathoracic opacity when it is abutting the lung borders of the mediastinum, that is heart or aorta, it will obscure that border because air from that region is displaced outward. Now when the opacity is not abutting the particular margin of the heart, either particular margin of the mediastinum, either a heart or the aorta, then we can say that it is not in contiguity with that border. Applying the Sellout signs, now let's try to identify the pathology which is given here. Now there is an opacity in the left lower lobe, but in an AP projection. So is it a left lower lobe pathology? But then you are able to see the left dome of the diaphragm very clearly, whereas the left heart border is not clearly made out. So thereby indicating that the pathology is anteriorly located because the heart is anterior. Now you take a lateral view of the chest, which shows there is a consolidation in the left lingular segment. Now this is a case 2, which is again you are able to see a diffuse increase in opacity of the left lung field, whereas the right lung is perfectly normal. You are able to see the left heart border clearly, that is aortic knuckle is well made out, and that means aortic knuckle is a posterior structure, but the left heart border is little obscured by the opacity. When you take a lateral view, this shows a opacity that is extending from superior to inferior. This is how the left upper lobe collapses. Now you also note that the compensatory hyperinflation of the left lower lobe. The bowing of the anterior bowing of the left major fissure is also noted in this X-ray. Now again we will go to the salute sign, where you see a opacity on the right side, but this opacity is obscuring the right heart border, but the right dome is very clearly made out. So we will put the pathology in the right upper lobe and right middle lobe, definitely not on the right lower lobe. Now in contrast, if you look at this particular X-ray, you have the right dome, right heart border is well maintained, but the right dome of the diaphragm is obscured. So we will put the pathology in the right lower lobe, because that is what is in close contact with the right dome of the diaphragm. So you are not able to define the right dome of the diaphragm in this X-ray. So this particular X-ray shows there are certain opacities in the right mid zone as well as in the left upper zone. Now in addition to that, you see prominent hilar shadows on the right side also. In a lateral view, again confirm that the pathologies are there in the right middle and left upper lobe. These patchy type of alveolar opacities indicate a mnemonic change. This is pneumonia in both upper lobe. Now this particular case, you have one cavity in the right upper lobe, and there is a fluid level within the cavity, and the surrounding lung is diseased. Whenever you see a cavity with the fluid level, and whenever the surrounding lung shows signs of inflammation, that means it is a cavitating pneumonia. So there are only few organisms which can cause cavitating pneumonias, commonly staphylococci and tuberculosis. This shows the cavitation with the fluid level. Okay, and this case shows bilateral upper lobe opacities, and you also note increased translucency over right upper lobe. Now this is nothing but a case of bilateral upper lobe tuberculosis, with one of the cavity in the right upper lobe giving way and forming a localized pneumothorax. The total lung is not collapsed. You see only the partial collapse of the right upper lobe underneath the pneumothorax. Now this is another case where you are able to identify increased lung markings in both the lung fields, flattening of the right dome of the diaphragm, and increased translucency, that is more focal in the right side as well as in the left mid zone. These focal increase in the translucencies indicates emphysematous bullous changes, and bilateral hyperinflated lung field indicates chronic obstructive airway disease. So this is a case of COPD with multiple bulla in both lung fields. Now this case shows an opacity in the right mid zone, and if you carefully look, the right costophrenic angle is also obliterated. Now is it a tumor? This is called as a pseudotumor, wherein the fluid is accumulated in the right major fissure, and the part of the fluid gets accumulated in the costophrenic angle, thereby obliterating the right costophrenic angle. If you had assessed the costophrenic angle, this sign of pseudotumor could have been easily appreciated well. And pseudotumor is a vanishing tumor. Once you treat the pleural effusion, these tumors will vanish. Now, this case shows an opacity in the right lower lobe, and the opacity is overlapped with the breast shadow. So, to define the opacity more, as I have told you earlier, we have taken a lateral view wherein the opacity is confined to the posterior segments of the right lower lobe. Again, a consolidation in the posterior segment of the right lower lobe. Now, here right and left heart border is obscured, and you see multiple streaky opacities projecting from both lung borders of the mediastinum, and this appearance gives an apparent cardiomegaly-like appearance. Now, when you take a X-ray in the after diuretic, what happens? All these opacities gets disappeared. So, this is nothing but a case of acute pulmonary edema, commonly after myocardial infarctions and cardiogenic edemas. Now, this characteristically disappears after a diuretic therapy. You will be able to, in the follow-up X-ray, you will be able to make out the heart borders very clearly. Now, we were talking about the opacities in the lung field. Now, we come to an opacity in the periphery of the lung field. That is, this particular case shows a opacity abutting the left chest wall. Now, whenever we talk about opacities abutting the chest wall, it can be a pathology in the periphery of the lung, or it can be a pathology from the pleura or from the chest wall. Now, how to differentiate whether it is from the pleura on the chest wall or is it a lung pathology is, the pleural pathologies are always having a wide base towards the pleura, and if you look at the tumor to the lung angle, that angle will be always obtuse. That shows a location of the pleural mass. Again, opacity that is obliterating the left costophrenic angle, and if you concentrate on the upper border of the opacity, that forms a curve shaped, that is a concavity upward. That is a case of left pleural effusion. This is a typical appearance of left pleural effusion. In contrast, you see here a lamellar effusion wherein you see the opacity forming a vertical stripe of line which is parallel to the left chest wall, and these are called as a lamellar type of effusions and more common in secondary to infections of the left lower lobe. Now, an opacity which is closer to the left hilum, an opacity which are closer to the hilums should be carefully assessed for the signs of malignancy. Depending on the age group, depending on whether there is cavitations or calcification and the appearance of the borders, it should be assessed, and these type of opacities are either carcinoids if it has a calcification, or if it has a irregular border, you have to think in terms of central type of bronchogenic carcinoma. And again, a peripheral lung mass here, that you find a well lobulated margin with a clear cut borders all around. It is a benign tumor of the lung. In this case, if this is a difficult case, if you carefully look at the left upper lobe, you will find a thin translucent lung which is actually showing the collapsed lung border, and you will find a small pneumothorax just superior to the collapsed lung, a subtle pneumothorax, not that much symptomatic. And again, another case with a compensatory hyperinflation of the left lower lobe. This is left upper lobe consolidation with collapse. Now, atelectasis, basically it means that there is a lung volume loss and the compensatory lung on that particular side, be it an upper lobe or a lower lobe, that shows a compensatory hyperinflation just to overcome the function of the affected lung. Now, in this X-ray, you find that there is a mediastinal shift to the left side. Right hemithorax, volume of the right hemithorax is comparatively larger, and the lung which is appearing is collapsed towards the right hilum, and you see an increased translucency over the entire right lung field. And this is a case of actually a tension pneumothorax, and after you find the lung collapse there, and there is a pneumothorax, and after inserting the ICD tube, that the mediastinum has returned back to its normal position and the lung has re-expanded. Now, you find multiple well-defined nodules in both lobes of lung, and these are characteristically called as cannonball appearance, which is very characteristic of vascular metastasis, that is metastasis through bloodstream, characteristically called as cannonball appearance. Now, this is a X-ray AP view shows a nodule in the right upper lobe, and nodule, the solitary pulmonary nodules are always a problem to the radiologists as well as to the clinicians, because you can neither brand it as a benign one nor as a malignant one. There are certain features which will help us to identify the characteristic of malignancies in these nodules. Now, benign nodules are usually homogeneous. Benign nodules can show a coarse, dense calcification. Benign nodules usually show a fibrotic strand in the adjacent lung field. Now, in case of malignancy, you always see a satellite like nodules in the nearby locality, or the peripheries appearing like a tethered appearance, what we call it as a, now like a tentacle, there are periphery of the mass will be showing a linear streaky appearances, and these appearances along with an increased density in the hilum indicates a malignant mass in the lung. So, these are solitary pulmonary nodules, has to be characterized either using a further clinical investigation or a CT scan. Now, extensive opacity in left upper lobe and with signs of cavitation and commonly with pleural thickening, commonly tuberculosis is the cause for such opacities in our country. Now, another case with the central type of opacity, but compared to the previous one, this is abutting the hilum. So, a hilar lymph node abutting the hilum can give rise to a central type of bronchogenic lesion like the appearance. So, should be differentiated from that based on the inseparability from the left hilum. So, a hilar mass will be superimposed over the hilum, whereas the lung mass will be seen in either anterior or posterior to the hilum. A widening of the superior mediastinum. This point should be very carefully noticed. This is only a subtle widening of the aorta. By obscuring the left heart border, you find a left, this is an early stage of fusiform dilatation of the aorta, and compared to the florid case, which is a saccular aneurysm arising from the ascending as well as the arch of aorta, causing a phrenic nerve palsy, resulting in elevation of the right dome of the diaphragm. Okay, cardiomegaly with prominent pulmonary bay and prominent pulmonary hilum with increased lower lobe vascular markings, and these are very characteristic of mitral valvular heart disease with secondary pulmonary pulmonary hypertension changes. Case with opacity in the left upper lobe with multiple acinar opacities in the left lower lobe. Now, these type of lesions are indicative of active tuberculous lesions. Whenever you see acinar opacities in a tuberculosis, you can boldly say these cases are active tuberculosis, because the cavity alone does not say whether it is an active or a quiescent disease. But when you have an acinar opacities along with the cavity, it is definitely an active tuberculous disease. A plaque of calcification along the right pleura, and these seeds of calcification represents a dense pleural calcification, and this can happen either due to asbestosis or due to chronic empyema, which are untreated or treated medically and resulting in fibrothorax like appearance on the right side. Now, this is an end stage tuberculous disease on the right side. You see dense hemithorax on the right side along with shift of the trachea as well as the heart to the right side. If you notice, the right sided ribs are totally collapsed and rather crowded, and the right hemithorax volume is reduced. A case of destroyed right lung with a fibrothorax. Now, cystic bronchiectatic changes in the right midzone. Multiple cavities are noted in the right midzone with the air fluid level, and this is a case of cystic bronchiectasis in right middle lobe with signs of acute inflammations. That is, the fluid level represents the acute inflammations. Now, it is always the not only the X-ray, you should have a clinical correlation. So, it is always the clinical examinations along with the X-ray interpretation, which will get at the diagnosis. Now, this brief lecture on interpretation of the chest X-ray would have helped you to have a clear idea on interpretation of the chest X-rays as well as the assessment of different pathologies. If there are any doubts, you are welcome to contact us for any clarification of the doubts. Thank you.